Hello, we'll be talking about nephritic syndrome and nephrotic syndrome. Basically, these are clinical manifestations. Definition of nephritic syndrome: this is nothing but inflammation of the glomeruli. Okay, so the basically glomerulus is nothing but a bunch of capillaries. They are inflamed. So generally, wherever there is inflammation, there will be hypercellularity or inflammatory cell infiltrate. Cell infiltrate. Okay, generally these cells will secrete some cytokines, interleukins, etc., which will damage the basement membrane or glomerular basement membrane. That leads to hematuria. Now, if this happens for prolonged duration, it can lead to formation of RBC casts in tubules. Okay, this is the first finding you have to remember. This is another finding you have to remember. Okay, because the glomerulus is injured or it is inflamed, there will be progressive decline in GFR. Now that will lead to azotemia. That will also lead to compensatory renin release. Now this renin release causes fluid retention. Fluid retention is also due to declining function of the kidney. Okay, now this fluid retention will lead to hypertension. Azotemia is another finding you have to remember. Hypertension is one finding you have to remember. Okay, this would be proteinuria. There will be proteinuria. I'll discuss the mechanism of proteinuria in nephrotic syndrome. Okay, what is nephrotic syndrome? Nephrotic syndrome is basically damage to the glomerular wall or barrier that leads to increased permeability. The membrane becomes permeable. Now, what is that membrane? We'll discuss it in 1 second. Okay, this leads to massive proteinuria. First finding you have to remember under nephrotic syndrome is massive proteinuria. Okay, a little bit of physiology. These are the visceral podocytes. This is the glomerular basement membrane, and this is the capillary wall. Together, these three layers act as a size and charge barrier. I have depicted the visceral podocytes being continuous, which is for the sake of representation. Generally, the visceral podocytes are like this. So there's a slit or some space in between them, which prevents loss of some substances, thus acting as a size barrier. The size barrier is also envisioned at the level of capillary. Okay, fine. Now, what is this charge barrier? The glomerular basement membrane generally contains some proteoglycans, glycoproteins. Tom Harshwell. Yeah. Anyway, basically, the glomerular basement membrane is negatively charged, so that prevents loss of proteins, because proteins are amino acids which are also negatively charged. But then that would explain that they would attract positively charged substances. Okay, so the crux of all this discussion is that this wall or this membrane acts as a size and charge barrier. Now, suppose there's an alteration in this barrier, or an injury or an insult to this barrier, that leads to proteinuria. Again, we have discussed proteinuria in under two headings actually. One is nephritic and one is nephrotic. Nephrotic, I'll write down the range for you. Nephrotic is around greater than 3.5 grams of protein per day. Nephritic, not so much. It is less than 2 grams per day. Okay, nephrotic is more of selective proteinuria. Now, what are the proteins here that are lost? One is albumin, the other is antithrombin 3, protein C, protein S. Now, albumin is lost. A property shared by all these proteins is that they have low molecular weight. Okay, this is non-selective. First, we have to discuss two principles here. In nephrotic syndrome, this is nephritic syndrome. Okay, in nephrotic syndrome, because albumin is lost, now often this loss far exceeds the the production capacity of the liver. So basically, loss is more than production. So that leads to a fall in colloid oncotic pressure. This leads to edema. This is generally visualized in periorbital regions and dependent areas. This edema can also be because of sodium and water retention. Why is there sodium and water retention? Just because of compensatory RAS activity and sympathomimetic activity. Sympathetic system. Compensatory sympathetic activation. This is another finding you have to remember. We also discussed that antithrombin 3 and protein C, protein S are lost. So we also discussed that antithrombin 3, these proteins are also lost. That leads to a hypercoagulable state. Now again that leads to renal vein thrombosis. A very idiopathic finding is that there will be lipidemia, hyperlipidemia, lipiduria, and increase in LPA. That was it. Thank you.